I'm Carla Pecoraro.
I'm Mel Akerman.
And I'm Anne Warfield, and we're your hosts of the Uterine Sound podcast, bringing you up-to-date information and all thing obs and gynae. This week, we're going to dive a little deeper into endometrial cancer. We'll cover workup, staging, and management. Let's do this with a case.
Today, you're seeing Pamela. Pamela is a 64-year-old lady who recently presented with post-menopausal bleeding and an endometrial thickness of 15 millimeters. Fortunately for Pamela, you listened to our episode on postmenopausal bleeding, and so you knew exactly what to do. Pamela underwent a hysteroscopy, dilatation and curettage and presents to your clinic today for her results. You bring up the histopath report and it states endometrioid adenocarcinoma. How do you approach this consultation with Pamela?
Well, firstly, I'd make sure we're in an appropriate setting. I'd invite Pamela to bring in a family member or friend and make sure we're in a private room. I'd then establish what Pamela already knows about the situation. Hopefully, she was counselled well before her HD&C and is aware that we were investigating her postmenopausal bleeding and thickened endometrium in order to rule out endometrial cancer. I would then prepare Pamela by telling her that we have received her histopathology results and unfortunately, they do show endometrial cancer. I would give Pamela some time to process this information and ask any questions that she might have. I would then follow this up by explaining the next steps in managing Pamela's endometrial cancer. This would include arranging staging investigations and then referring to the local Gynecology Oncology department for a multidisciplinary team meeting. At this meeting, the radiologists, pathologists, medical oncologists, radiation oncologists, and gynecology oncologists all review the investigations together in order to come up with the best management plan for Pamela, which may include surgery, chemotherapy, radiotherapy, or a combination of both. It's really important when breaking bad news like a cancer diagnosis to a patient that you give them a follow-up plan and an expectation of when they can expect things to happen. Receiving a cancer diagnosis can feel very scary, and the time between finding out your diagnosis and knowing what kind of treatment you'll need or what your prognosis is can be a really turbulent and uncertain time. By clearly outlining the next steps for Pamela and maintaining open lines of communication, you can really help give her some structure through this limbo of uncertainty. I sometimes find that ringing radiology and booking a time for the imaging right then and there can be really helpful for patients who may not be able to navigate bookings on their own.
So let's go through the staging of endometrial carcinoma. What are the investigations that you would arrange for Pamela before referring her to Gynecology Oncology?
Staging for endometrial cancer is typically surgico-pathological, meaning that the staging is based on surgery and the histological verification of the tumour type, grade, and extent of the tumour. Imaging is not part of the FIGO staging system, but it might be used to determine the extent of the local disease and the presence of lymph nodes prior to surgical treatment. Most gynecology oncology departments have standardized investigations that they require to be sent through with new referrals for gynecological cancers. For endometrial cancer, these investigations typically include a CT chest abdo-pelvis and a CA-125. The CT scan is checking for distant metastatic disease, and the CA-125 can sometimes be used for surveillance of patients after initial treatment if the level was initially elevated. For young patients who may wish to preserve their uterus, an MRI is typically performed to assess the depth of myometrial invasion. A full blood count, UEC and LFTs, is also typically performed in order to assess for perioperative risk and the ability to tolerate adjuvant therapy such as chemotherapy. Oh, and don't forget the patient's height, weight, and BMI.
Okay, so we arrange our CT chest abdo-pelvis and CA-125 for Pamela and refer her to our local GONC MDT meeting. What can we expect to happen at this meeting?
GONC MDT meetings are typically performed for all patients with a new diagnosis of gynecological malignancy. The purpose of the meeting is to get an expert review of the pathology and imaging and ensure the best management plan moving forward. The histopathology of the endometrial biopsy is reviewed to determine the histological type, tumour grade, and molecular subtype. This allows the MDT to plan for surgical staging, specifically the extent of lymph node resection that is likely to be required. For Pamela, we can see that she has an endometrioid adenocarcinoma. If you remember from our previous episode, we said that endometrioid carcinoma is also assessed by grades. The grade is determined by the degree of cell differentiation and the presence of solid growth pattern. Grade 1 is considered well differentiated and contains less than 5% of solid growth pattern. Grade 2 is moderately differentiated and contains 6 to 50% solid growth pattern. And grade 3 is poorly differentiated, containing more than 50% of a solid growth pattern. If the pathologist identifies notable nuclear atypia that is not in keeping with the architectural grade, then this actually raises the grade of a grade 1 or 2 tumour by 1. Now, this grading system really only applies to endometrioid cancers. Serous and clear cell carcinomas are usually considered high grade by definition.
Okay, so Pamela undergoes her staging investigations. The CT chest abdo-pelvis is negative, her CA125 is normal, and the GONC-MDT determines that she is a grade 1 endometrioid adenocarcinoma. Pamela is invited down for an appointment with the gynecology oncologists, where they plan her surgical staging procedure. You are now the registrar working in the Gynecology Oncology clinic and are asked to book her surgery. What procedure do you arrange for Pamela?
The surgical staging procedure for endometrial adenocarcinoma includes a total laparoscopic hysterectomy and bilateral salpingo-oophorectomy, plus sentinel lymph node biopsy. Peritoneal washings can be performed, although there is some argument about whether this really needs to be routine or not, since the majority of cases, the findings from a peritoneal cytology did not influence the decision for adjuvant therapy. We used to stage endometrial cancer with a midline laparotomy. However, there is consistent data from randomized control trials, including the LAP2 trial and the LACE trial, that laparoscopic hysterectomy compared with open hysterectomy results in lower morbidity and comparable oncologic outcomes. As a result, minimally invasive surgery is preferred. Ovaries are typically removed because of the possibility of metastatic disease. However, ovarian preservation may be considered in premenopausal women with low-grade early-stage disease. The goal of surgery is to remove the primary tumour and to identify prognostic factors to determine whether adjuvant therapy is required. Upon entry into the abdominal cavity, a systematic inspection is performed to assess for the presence of intra-abdominal metastases. Peritoneal washings are then collected if required, and the hysterectomy BSO is performed. Now, if Pamela was thought to have higher stage endometrial cancer like stage 3 or 4, then the goal would still be cytoreductive surgery with the aim of complete resection.
Now let's talk lymph nodes. Lymph node evaluation is the most controversial topic in the surgical management of endometrial carcinoma. On the one hand, evaluation of the lymph nodes is required to accurately stage the disease, inform prognosis, and determine the need for adjuvant therapy. On the other hand, lymphadenectomy is associated with additional surgical morbidity, and it's unclear whether it actually improves overall survival. In general, the options for lymph node evaluation include no lymph node dissection, systematic lymph node dissection in high-risk patients, routine sentinel lymph node dissection, and systemic lymphadenectomy in all patients.
The management of lymph nodes in endometrial cancer has changed over time. Before the 1980s, systematic lymphadenectomy was not performed. Then, the GOG33 study in 1987 described the increased risk for pelvic lymph node mets in endometrial cancers that were higher grade or more deeply invasive into the myometrium. From then on, complete lymphadenectomy of both pelvic and para-aortic lymph nodes was performed. Since the majority of patients did not have lymph node mets, and a lot of patients who underwent routine lymphadenectomy experienced the morbidity of lower extremity lymphedema, researchers then reconsidered the value of routine lymphadenectomy. 2 RCTs, including the notorious Aztec trial, compared routine lymphadenectomy with lymphadenectomy only if the lymph nodes were enlarged. Both of these studies showed that routine lymphadenectomy did not offer a survival benefit in patients with endometrial cancer. However, the quality of the results of these studies has been called into question, and many surgeons are not convinced of the data, calling for more trials on the matter. Then, less invasive techniques were developed, including lymphatic mapping and sentinel lymph node dissection. These techniques have been shown to be feasible and have a low false negative rate for the detection of positive lymph nodes. They are also associated with lower rates of complications, like lymphedema, and as a result have become the preferred mode of lymph node assessment by many organizations worldwide. Although sentinel lymph node biopsy has now become the standard of care, there are actually no randomized studies comparing sentinel lymph node dissection with alternative strategies in evaluating the retroperitoneal lymph nodes.
So how do you actually do sentinel lymph node dissection?
It's actually a really cool technique. The most common technique is to inject about 2 mL of indocyanine green into the superficial and deep cervical stroma at 3 and 9 o'clock prior to the hysterectomy. The dye then spreads to the closest lymph node in about 15 minutes. An infrared camera is used to detect the ICG, which glows neon green, and locate the sentinel lymph node. This lymph node is then identified, removed, and sent for histopathology. Mapping is typically done bilaterally, and the optimal detection of the dye occurs between 15 to 60 minutes.
Does the lymph node mapping work every single time? What do you do if the lymph nodes don't map?
A non-mapping pelvis occurs in about 6% of patients. In these patients, most gynecologists will use a selective lymph node dissection strategy. This is typically done by assessing the Mayo criteria to determine whether a lymph node dissection should be omitted or whether a complete lymphadenectomy is required. The Mayo criteria is based off a study done in 2000 that showed that patients with grade 1 to 2 tumours of endometrioid histology with tumour size less than 2 centimetres in diameter with less than 50% myometrial invasion are unlikely to have nodal disease, and thus lymphadenectomy can be omitted. For those with the high-risk criteria and in whom lymph node mapping doesn't work, a complete lymphadenectomy should be performed.
So, is it just pelvic nodes that should be sampled, or para-aortic nodes as well?
In general, for low-grade cancers, we just do the sentinel lymph nodes or pelvic nodes. But in patients with high-risk cancers, we might consider sampling the para-aortic nodes. Indications for para-aortic node sampling include suspicious aortic or common iliac nodes, grossly positive adnexae, grossly positive pelvic nodes, high-grade tumours showing full thickness myometrial invasion, or clear cell, papillary serous, or carcinosarcoma histological subtypes.
Okay, so Pamela agrees to undergo the planned surgery and is booked for a TLH, BSO, and washings and sentinel lymph node biopsy. She has the surgery the next week and is discharged the following day. What happens now?
So now we go back to the MDT. The results of the surgical staging are again evaluated at a multidisciplinary meeting, but this time we have more information. At this meeting, the team will consider a few things: the histological subtype, the tumour grade, molecular subtype, the depth of myometrial invasion, lymph node involvement or lymphovascular space invasion, involvement of the cervix or adnexae, and the status of peritoneal washings taken at surgery. This information helps us to accurately stage the endometrial cancer and to decide on the need for adjuvant treatment. For that, we use the FIGO staging system.
The FIGO staging system classifies the endometrial cancer into stages 1 to 4, and there have actually been some major changes to the staging system since 2023, especially to stage 1. Previously, we used to have stage 1 as limited to the uterine corpus, with 1A being less than 50% myometrial invasion and 1B being greater than 50% myometrial invasion. Unfortunately, this has changed and subsequently become a lot harder to remember. So here goes. Stage 1 is where the tumour is confined to the uterine corpus. 1A is limited to the endometrium or non-aggressive histological type with invasion of less than 50% myometrial thickness. 1A1 is non-aggressive histotype limited to a polyp or confined to the endometrium. 1A2 is non-aggressive histotype involving less than 50% of the endometrium. And 103 is low-grade endometrioid carcinomas limited to the uterus and ovary. 1B involves non-aggressive histological type with invasion of greater than 50% myometrial thickness. And 1C are aggressive histological types limited to a polyp or confined to the endometrium. Stage 2 involves direct invasion of the cervical stroma or with substantial LVSI or aggressive histological types with myometrial invasion. 2A is invasion of cervical stroma with non-aggressive histotypes. 2B is substantial LVSI of non-aggressive histotypes. And 2C is aggressive histological types with any myometrial involvement. Now we're getting into our advanced stage disease. So stage 3 involves local or regional spread of the tumour of any histological subtype. 3A involves the uterine serosa or adnexae. 3B involves extension of the tumour into the upper vagina, parametrium, or pelvic peritoneum. And 3C involves lymph nodes. 3C1 is the pelvic lymph nodes, and 3C2 are the para-aortic lymph nodes. And finally, stage 4 involves distant metastases to the bladder, bowel, or distant mets. 4A involves a bladder or bowel mucosa. 4B involves abdominal peritoneal metastases beyond the pelvis. And 4C involves distant mets, malignant ascites, peritoneal deposits, or lymph node disease above the renal hilum or in the inguinal region.
Oh, Mel, how in the heck am I ever going to remember that?
Have you heard of the FIGO app?
Ooh.
It's this little purple app that has all of the FIGO staging for the gynecological cancers. I use it all the time. As for how to remember the staging for exams, you're just going to have to memorize it. In general, stage 1 is limited to the organ, stage 2 is local spread, stage 3 is regional spread, and stage 4 is distant metastases. I use little acronyms to help me, like USA and UVP, to differentiate stage 3A and stage 3B. USA is uterine serosa and adnexa, whereas UVP is upper vagina, parametrium, and pelvic peritoneum. There's also some textbooks which you give little pictures, which I also help to picture exactly what the stages are. If anyone is interested in a more detailed breakdown about why FIGO have made these changes to the staging system, have a read of the paper conveniently titled FIGO Staging of Endometrial Cancer 2023. But basically, the changes were made in order to better reflect the prognosis, treatment options, and the chance of recurrence.
Oh, and don't forget the addition of molecular classification to make staging that little more confusing. POL mutations indicate a favourable prognosis. MMR deficiency and no specific molecular profile indicate an intermediate prognosis and do not alter the state, while P53 mutation indicates a poor prognosis. In early endometrial cancer, the presence of POL or P53 mutations now modifies the FIGO stage, with POL mutations downgrading the stage and P53 mutations increasing the stage. Advanced endometrial cancer is not changed through molecular subtyping, although more prognostic information can still be obtained, and FIGO still recommends recording the molecular class for the purpose of data collection.
I actually find this really interesting. When I was studying for my exams, the staging was so much more simple, and we were really only just starting to think about the role of molecular subtypes. I think I had the 4 subtypes listed very randomly in my notes, sort of as an afterthought. So it's really cool to see how in just a few years, something that seemed so insignificant, well, to me anyway, has now proved itself and been incorporated into something so important as staging. There must just be so many smart people in the background working hard on all of this cancer research to make all these changes happen.
Absolutely. Can't wait to see what happens in the next 4 to 5 years.
Yeah, make our staging
Alrighty,
harder.
so back to Pamela. Yeah, way more acronyms to memorize. Okay, so back to Pamela. Pamela has her results reviewed at the GONC MDT and she is given a revised stage of her cancer. Histopath of the uterus revealed that the cancer had spread into the myometrium. However, it involved less than 50% of the myometrial thickness. As a result, the stage is confirmed as stage 1A2, grade 1 endometrioid adenocarcinoma without LVSI. Her molecular subtype is MMR deficiency. What do we do now?
So now we need to assess whether Pamela requires adjuvant therapy. And to do that, we need to assign a risk classification to her disease. Early stage endometrial cancer is classified into low, intermediate, high risk, intermediate, or high risk on the basis of the risk of pelvic and distant recurrence. Patients with a low risk endometrial cancer will have all of the following characteristics. Cancer is the endometrioid type, histological grade 1 or 2, and limited to the endometrium or invading less than 50% of the myometrium with no LVSI. It's possible that this definition might extend to all cancers with focal LVSI and higher stage cancers with POL mutations. Given that Pamela meets all these criteria, her cancer is classified as low risk.
The main risk in patients with low-risk endometrial cancer is local recurrence, which usually occurs at the vaginal vault. Although adjuvant radiation therapy can be used to reduce the risk of recurrence, it has not been shown to be of benefit in patients with low-risk disease. The chance of recurrence is less than 5%, whilst the rate of radiation therapy complications is much higher than this. Furthermore, studies have not shown an improvement in overall survival, and in fact an increased risk of death with use of radiation therapy in low-risk patients compared with observation alone. Since Pamela is low risk, she should not be treated with adjuvant radiation therapy. Pamela can be reassured that even without adjuvant therapy, she has an excellent prognosis with a low recurrence risk and an expected survival of more than 90%. Even if Pamela does have a recurrence, it can usually be successfully treated with radiation therapy.
Okay, so since Pamela has a low-risk endometrial cancer, she doesn't require adjuvant therapy and can be managed with surveillance alone. What might happen if Pamela was intermediate risk?
Intermediate risk cancer is a little bit confusing, and to complicate things further, it's divided into low intermediate risk and high intermediate risk. Traditionally, this division was based on age and the following 3 risk factors: the presence of deep myometrial invasion, grade 2 or 3 histology, and the presence of LBSI. Women had a high intermediate risk disease if they are greater than 70 with 1 risk factor, age 50 to 69 with 2 risk factors, or greater than 18 with all 3 risk factors. Now, with new evidence comes more changes, and the latest 2022 ESMO guideline has redefined the intermediate risk and high intermediate risk groups to better reflect the risk of recurrence. It's a bit confusing to list what falls into what category, so we'll put the table up on our Instagram for your reference. Basically, patients with low intermediate risk disease have an excellent prognosis with a less than 15% recurrence rate. Vaginal brachytherapy has been shown to reduce the recurrence rate, but that does not increase overall survival, and therefore omission could be considered. The decision for adjuvant vaginal brachytherapy versus observation alone should be individualized and made in conjunction with the patient and the multidisciplinary team. If vaginal brachytherapy is administered, it's typically started 3 to 9 weeks after surgery and is given once to twice weekly on an outpatient basis.
Patients with a high intermediate risk endometrial cancer have a recurrence rate of about 40% and should be considered for radiation therapy to reduce that recurrence risk to less than 5%. These patients are typically treated with external beam radiation therapy. External beam radiation therapy treats the parametrium and pelvic sidewalls. You can also have extended field radiotherapy if para-aortic lymph nodes are involved. The addition of chemotherapy could also be considered. However, the evidence is a bit unclear in this area. The main concern is whether the chemotherapy is likely to improve overall survival versus the increased frequency of adverse events. Once again, the addition of chemo should be considered on a case-by-case basis.
Okay, so low intermediate risk can have observation or vaginal brachytherapy, and high intermediate risk should have external beam radiation therapy plus or minus chemotherapy. What about if Pamela had high-risk disease?
Patients are classified as having high-risk endometrial cancer if they have any of the following: all stages and all histologies with P53 mutation and myometrial invasion, all stages with a high-risk histology and myometrial invasion, and all stage 3 or 4 disease. High-risk patients have a high risk of recurrence and are typically recommended to have treatment with a combination of adjuvant chemotherapy and external beam radiation therapy. Chemotherapy is either given concurrently or sequentially, with chemo being followed by radiation therapy. There can also be the option of chemotherapy alone. These cases are quite complex, especially now with the addition of molecular subgroups, so we recommend leaving these decisions to the experts of your local GONC unit.
Now, obviously, we want to confine the use of radiotherapy to patients who may actually benefit from the treatment, hence why we don't recommend radiation therapy to patients with low-risk disease who are already at low risk of recurrence. We know that radiotherapy reduces recurrence, but does not improve overall survival rates, and that one of the reasons we are sparing with it is because of the risk of side effects and complications. So what are these side effects of radiation therapy?
The side effects for radiation therapy can be divided into short and long-term effects. Short-term effects include fatigue, diarrhea, nausea and vomiting, skin changes like erythema or blistering, radiation cystitis, proctitis or vaginitis, and low blood counts. Long-term side effects include vaginal dryness or stenosis, dyspareunia, the need to use vaginal dilators, premature menopause, lymphedema, osteoporosis and pelvic fractures, radiation proctitis or cystitis, fistula formation, and poor wound healing.
Okay, so now that we've established the treatment options for endometrial cancer, let's talk about follow-up. What kind of surveillance do endometrial cancer survivors need?
More than 80% of patients diagnosed with endometrial cancer will have an excellent prognosis, and so being aware of the long-term effects of endometrial cancer and its treatment are important. The biggest thing we monitor for is recurrence. Most endometrial cancer recurrences occur within 3 years of initial treatment and are usually symptomatic with vaginal bleeding or pelvic pain. There's actually no evidence from RCTs for the role of intensive, doctor-led, hospital-based surveillance in endometrial cancer follow-up evaluation. And there's also no consensus on what testing should be used. Therefore, surveillance can be adjusted to risk factors. For low-risk groups, the suggested frequency of follow-up is every 6 months with physical and gynae examination for the first 2 years, and then yearly until 5 years. Patients should be educated on concerning signs and symptoms such as vaginal bleeding and pelvic pain, and advised to contact the clinic sooner if this occurs. In the high-risk groups, physical and gynecological exams are recommended every 3 months for the first 3 years, and then every 6 months until 5 years. Routine imaging is not typically recommended since it only detects about 15% of recurrences. However, it could be considered by the treating team for high-risk patients with node extension. Your local Gynecology Oncology unit will have their own protocol for surveillance and should be referred to.
Okay, so let's say we're doing our surveillance for Pamela. At her 18-month checkup, Pamela reports vaginal bleeding. You do a speculum examination and see a small nodule suspicious for recurrence. What do you do now?
Recurrences of endometrial cancer typically do occur at the vaginal vault or within the pelvis. If a recurrence is suspected, the first thing we should do is screen Pamela for distant mets with a PET CT and an MRI and a referral to GONC. If the recurrence is isolated to the vagina and Pamela has not had radiotherapy before, she can be given salvage radiation therapy with really good effect. In some patients, this may be completely curative. Pamela can be reassured that even with an isolated vaginal recurrence, she still has a 73% 3-year survival rate. Now, if Pamela was to have a pelvic recurrence, the 3-year survival rate is much lower at 8%. In this situation, radiation therapy with consideration of systemic therapy could improve survival. Now, if Pamela has already had radiation therapy, then you don't really want to give it again. In this case, surgery could be considered, but only if complete resection appears possible and the morbidity is acceptable to the patient. This surgery usually involves pelvic exenteration, which is the removal of all organs from the pelvis. That means the bladder, urethra, rectum, anus, uterus, cervix, ovaries, and part of the intestine. As you can imagine, this is a pretty intense surgery with considerable morbidity to the patient, and it may not be appropriate for all patients. For recurrent disease not amenable to surgery or radiotherapy, chemotherapy or hormonal therapy could also be considered. The standard chemo regime is carboplatin and paclitaxel, and the hormonal treatment options usually include progestins like medroxyprogesterone acetate or alternative options like tamoxifen, aromatase inhibitors, and fulvestrant.
The other important thing to be aware of in endometrial cancer are the long-term symptoms and risks. The main long-term symptoms reported by patients are fatigue, psychological distress, sexuality and genitourinary disorders, chronic pain, lymphedema, and neuropathy. Obesity is associated with low quality of life and physical function. Lifestyle interventions may improve fatigue, physical functioning, and result in weight loss. Psychoeducational programs could improve mood disorders and sexuality complaints. Therefore, promotion of regular exercise, healthy diet, and weight management should be addressed with all endometrial cancer survivors. Most endometrial cancer survivors end up with comorbidities from obesity, cardiovascular events, and diabetes, so pay particular attention to reducing these risk factors.
So now let's touch on a couple of tricky situations. How might our management change if Pamela was actually a 30-year-old woman?
Our management recommendations would still remain the same. However, in this patient group, we do need to consider 2 things. Firstly, a desire for fertility, and secondly, the possibility of an estrogen-related underlying condition like an ovarian granulosa cell tumour. If 30-year-old Pamela wanted fertility preservation and she had a stage 1A grade 1 endometrial cancer without myometrial invasion, then medical management could be considered. These patients can be treated with a Mirena or oral progesterone at quite high doses. typically medroxyprogesterone at about 400 to 600 milligrams per day. In cases of a complete response, conception must be encouraged immediately, and Pamela should be referred to a fertility clinic as soon as possible. Although there are successful outcomes with this approach, fatal recurrences of endometrial cancer have occurred, and so the patient really needs to be counselled on the risks and benefits of a non-standard treatment. Hysterectomy should be recommended as soon as childbearing is complete.
What about patients who are not suitable for surgery?
In some patients, surgery may not be an option. This is usually because of morbid obesity or severe comorbidities like heart disease. In these cases, primary radiotherapy can be used. Brachytherapy alone is usually recommended, with the addition of external beam radiotherapy if there is a high-risk involvement of lymph nodes. High-dose progestins could also be considered, and trials are underway for this.
What about a patient who has an incidentally detected endometrial carcinoma at the time of hysterectomy for another cause?
Women who did not undergo formal nodal staging as part of their surgery are technically unstaged. For low-risk patients, reoperation is not recommended as the chance of lymph node involvement is low, and so surveillance can be considered. For intermediate-risk patients, the data supports pelvic radiation therapy to reduce local recurrences without reoperation to complete staging.
And finally, who do we test for Lynch syndrome?
So you might have noticed that Pamela's molecular subtype was MMR deficiency. All endometrial cancers are assessed for MMR deficiency in order to work out the presence of Lynch syndrome. The next step in endometrial cancer analysis is to determine whether the MMR deficiency was due to loss of MLH1 with hypermethylation of the MLH1 promoter. Patients with MMR deficiency without the MLH1 hypermethylation are more likely to have Lynch syndrome and should be referred for genetic counselling. Patients with the MMR deficiency with MLH1 promoter hypermethylation do not warrant a referral to a geneticist.
Okay, now this has been a massive episode. So let's break it down into the key points that you need to know. Once you've made a diagnosis of endometrial cancer, you need to inform the patient, arrange staging investigations, and make a referral to Gynecology Oncology. The staging investigations include a CT chest abdo-pelvis or a PET scan, a pelvic ultrasound or a pelvic MRI if the patient is wanting to preserve fertility, CA125, a full blood count and a Chem20, and calculate the BMI.
FIGO staging is based on surgery, histopathology, and molecular subtypes. The typical surgery would include total laparoscopic hysterectomy plus bilateral salpingo-oophorectomy plus or minus peritoneal washings plus a sentinel lymph node biopsy.
Lymph node evaluation is controversial, but the currently accepted practice is sentinel lymph node dissection for all patients, pelvic lymphadenectomy for high-risk patients with suspicious nodes, and consideration of para-aortic lymphadenectomy for suspicious aortic or common iliac nodes, grossly positive adnexa, grossly positive pelvic nodes, high-grade tumours showing full-thickness myometrial invasion, or clear cell, papillary serous, or carcinosarcoma histological subtypes.
Endometrial cancer is staged according to the 2023 FIGO staging guideline. Stage 1 is where the tumour is confirmed to the uterine corpus. 1A is less than 50% of the myometrium, 1B greater than 50% of the myometrium, and 1C aggressive subtype in a polyp or confined to the endometrium. Stage 2 involves local invasion of the cervical stroma, substantial LVSI, or aggressive histological types with myometrial invasion. Stage 3 involves regional spread to uterine serosa or adnexa, upper vagina, parametrium or pelvic peritoneum, or pelvic lymph nodes. And stage 4 is distant metastatic disease to bowel or bladder, abdominal peritoneum, or distant mets.
Staging is further classified based on histological grade for endometrial cancers and molecular subtypes. A POL mutation has a good prognosis and downgrades the stage, whereas a P53 has a poor prognosis and increases the stage. If a patient has an MMR deficiency, you need to check for an MLH1 promoter hypermethylation to determine whether the patient needs a referral to a geneticist for Lynch syndrome.
Once staging is complete, early-stage endometrial cancers are classified as low risk, intermediate risk, high intermediate risk, and high risk on the basis of risk of recurrence. Low-risk cancers are treated with surgery alone and have a good prognosis with a less than 5% risk of recurrence. Intermediate-risk cancers may be treated with vaginal brachytherapy or observation alone. High intermediate-risk cancers may be treated with external beam radiation therapy plus or minus chemo, and high-risk cancers are usually treated with a combination of chemotherapy and radiation therapy.
Surveillance is recommended for all endometrial cancer patients. For low-risk patients, examination is performed every 6 months for 2 years, then annually for 3 years. For high-risk patients, examination is performed every 3 months for 3 years, then every 6 months for 2 years.
Recurrences usually occur in the first 3 years and are often symptomatic with vaginal bleeding or pelvic pain. If a recurrence is detected, the patient should be sent for staging investigations, MRI, and a CT PET and referred to GONC. Isolated vaginal recurrences have a good prognosis, whereas central pelvic recurrences have a poor prognosis. If a patient has not had radiation before, then most recurrences can be treated with salvage radiation. If a patient has had radiation before, then recurrence can be treated with pelvic exenteration. Rarely, chemotherapy or hormone therapy may be used. Now, I just wanted to share a couple of study tips I had. So when is radiation indicated in the treatment of endometrial cancer? 1, primary treatment, so that's in those who are medically unfit or inoperable disease. 2, adjuvant treatment, like we were saying with intermediate risk, high risk disease. 3, recurrent disease, like we said, in those with vaginal recurrence who haven't had radiation. And 4, palliation to control symptoms. And as far as the side effects of radiation, the acute ones I remember is just itis, so everything. Enteritis, cystitis, vaginitis, proctitis. And the late toxicity, you also have the itises, plus the ones that we've kind of already mentioned, stenosis, adhesions, fistula, sexual dysfunction, quality of life, and pain. Anyway, thank you for listening to this week's episode of the Uterine Sound podcast. You'll find our summary slides later on Instagram this week. If you have any comments, questions, feedback, or you want to fact check us, please reach out to us by email at theuterinesound@gmail.com. You can also reach us on Instagram and Facebook at The Uterine Sound and our website www.theuterinesound.com.